Hello and welcome to Different Conversations, where every week we have a different academic from the College of Liberal Arts and Sciences, University of Westminster. My name's Brad Elliott, and with me this week I have Dr. David Gaze. David, hello. How's it going today?
Hi Brad, how are you doing?
I'm admiring your haircut actually. I've got the COVID-19 length,
Yeah,
and you've really been doing a bit of self-care up there.
yeah, it's the beauty of having your own clippers.
I think,
I'm very sure.
Something I could definitely invest in. I think I needed a haircut in February, and it's now been about 4 months. And
Yeah.
the longest my hair has literally ever been. But not really what we're here to talk about, I'm guessing, is it? So we work in the same department. We know each other quite well in the School of Life Sciences. But for people watching or listening in, perhaps you could tell us a bit about yourself, who you are, and what your research is about.
Okay, yes. So my name is Dr. David Gaze. I am a lecturer in clinical biochemistry at the University of Westminster. I have a professional background, so I worked in the NHS for almost 20 years and worked within chemical pathology and clinical biochemistry. And I also did a lot of research. So my background of research is in cardiovascular disease and in particular, biomarkers to indicate cardiac disease and progression. So that's sort of my professional background. And then I moved to Westminster about 4 years ago and took up a purely academic role. So it's bringing professional practice from biomedical sciences into our courses within life sciences.
That's a very succinct way of summarizing a career that has publications and outputs measured in hundreds.
Yes. Okay. So
a modest summary, shall we say, Dr. Gaze?
Yeah. So I think publication-wise, we're sort of it's over 250 papers, 13 book chapters, and I'm co-editor-in-chief of Practical Laboratory Medicine as well. So I see things from both sides of the coin of being an active researcher and also from the publishing side as well.
What was it like moving from a clinical environment and a clinical job into academia? There must be very different worlds sometimes.
Well, being at St George's, I did have actually links to both the medical school and the NHS. So I had a sort of taster, if you like, of doing that. Plus, I was also external examiner at Westminster for a number of years. So I was used to being in the environment at Westminster. And obviously, we have a very prescribed teaching on our courses, certainly for biomed, because of the fact that we have to fulfill accreditation purposes to the Institute of Biomedical Sciences. So in reality, it's a very easy switch from doing what we do routinely and taking that in the professional sense and the practical sense into teaching students at undergraduate and postgraduate level.
Okay, so not that extreme at all. I was thinking about
not really.
That cliche of, let's say, what we're watching ER at the moment, of the cliche of the clinical environment of very exciting, very fast-paced world.
Yeah. Not all of medicine is like that.
I'm disappointed, honestly. Anyway, if I had to, in my mind, summarize your research from a layperson's point of view, I would think your research is about development and implementation of tests, of assays, of blood tests, of diagnosis almost in kind of clinical testing environments. In that regard, something called troponin is probably what you're most famous for in the world. So what can you tell us about troponin, bearing in mind we're not all well-published scientists?
Okay, so troponin is a group of proteins, actually. There's 3 different proteins, and they are housed within the cells of muscle tissue. So there are troponins that are found in the heart, and there are troponins that are found in skeletal muscle. And what they do in a nutshell is they act as a molecular key to regulate the process of muscle contraction. So they control contraction and relaxation, and in particular, there's 2 in particular that are important. One is troponin T and one is troponin I, and they are antagonistic to each other. So they are involved in contraction and relaxation of muscle.
Kind of the reason we're talking today is you recently wrote a piece about troponin and links to COVID-19. What's the link between a muscle protein and a global pandemic that's caused by a virus?
Okay, so sort of the background history of the troponins and why they're useful in cardiac disease is the fact that they're found within the cells. And when you have damage to those cells, the proteins are released. We don't quite know the full mechanisms, but they either leak out or they're actively released into the circulation. And we can use that as a measure of how severe the damage to the heart is. So we see this in patients that have chest pain, that have heart attacks, or they have angina. But we also see this in patients that have other conditions which affect the heart as well. And the list is as long as your arm. But in particular, with COVID, what we're seeing is that patients have a massive systemic inflammatory response, and it causes damage to all the muscles in the body, and in particular for the heart as well. So the troponins are released into the circulation and can be used as a measure of how severe the infection is, and is useful also in the way in which we can treat patients with COVID-19, because if they're responding to treatment, the troponin value should come down. So we're now in a situation where we can use it as a marker of prognosis of how well these patients are doing on their road to recovery.
And so does that mean there's cardiac or heart involvement in infection or recovery from COVID-19?
Yes, so the underlying pathology that we see in the heart is in severe cases, and that's the other important part here, is that it's the cases that are severe that require mechanical ventilation. They have more viral load, and those have more damage to primarily the lungs, but also the heart. And what we're seeing is what's known as a myocarditis. So it's very different to what we would see in patients that have a heart attack. What we're having here is an inflammation process going on in the body. It's affecting the heart, and the cells are becoming toxic and lyse and release those troponins into the circulation.
Okay, so that infection's getting worse, the cells lyse, they're dying, and they're bursting open and releasing this marker, and that's what you're using it for, basically.
That's absolutely true, yeah.
I think as a life scientist, and not too foreign to this field as well, one of the things that surprised me most is how cardiovascular a lot of the effects were in severe COVID-19 infections. So, for example, in a normal infection, yes, you get infection, you get inflammation, you get resolution, and you get better, or you get inflammation and you don't get resolution. You might see sepsis, for example. But we're really seeing coagulation disorders. We're seeing heart cardiac involvement. We're seeing a much more complicated set of outcomes here than we're used to seeing in a viral infection, aren't we?
Yeah, absolutely. And you know, COVID has only been around for a number of months, so we're learning all the time. We're having different experiences across the globe as to how people are responding to it. And yes, you're right. You know, the pathology is being worked out as we're progressing. So we know from the original data set from Wuhan that there was primarily a lung involvement, but over time, and especially with the second outbreak in Italy, the data from Italy was more suggesting there was coagulation disorders and cardiovascular involvement. And we also now have, obviously, data sets where we can look at people's medical history. Mm-hmm. And one of the biggest things is the fact that there's underlying cardiovascular diseases that seem to contribute to worsening infection in these patients. So it may be the fact that there is just a systemic vascular inflammation, which is what we have in cardiovascular disease, which predisposes to the acute events such as a heart attack. But those inflammatory processes, along with lifestyle, diabetes, other risk factors, are all additive to the risk of poor prognosis in patients who get COVID-19.
Okay, so from me trying to understand this point of view, so COVID-19 is putting a kind of a load upon you, and you can get worse or recover. But if you have underlying conditions, so maybe you had a slight sensitivity to infection or a cardiovascular event that might be undiagnosed, or something, no, event's a bad word, but a condition that's undiagnosed, or diabetes or metabolic syndrome, it just adds on top of that, makes you more likely to tip over a threshold.
Yes, so obviously with any disease process, the more risk factors you have, the more likely you are going to have a disease process. One of the other things with COVID-19 is also the influence of the ACE2 receptor, which is the binding point for the entry into the cells. And we know with cardiovascular disease and patients that have inflammation, they have low-grade cardiac ischemia, sort of, again, the prerequisites to the big cardiac problems, those patients have higher numbers of receptors on the cell surface. So it probably means that we're getting more of the virus into the cells and causing more damage purely by the nature of the fact that the entry key into the cell is there in greater numbers.
So this ACE2 receptor is how the virus gets inside of cells. Is that what you're saying?
Yeah.
And
Absolutely,
then I was going to ask before, when we talked about the Wuhan data versus some of the Italy data and looking at population results and whether or not there was any indication there of different people being affected in different ways. Is this perhaps one of the reasons why we're seeing vastly different effects on populations in very different parts of the world? Is there ethnic differences in human responses here?
Yeah, so obviously ethnicity is a key risk factor for COVID-19. And we know about the link to Black and Asian minority populations. And we've seen this in a number of different cohorts, primarily in the UK, Italy, and in the USA. One of the other factors which obviously we do need to consider here is the fact that in China, the incidence of cardiovascular disease is quite low. So actually what we're seeing, so the risk factors are probably negated in that population compared to what we see in Europe and the US. So it may be the fact that we're seeing more of the severe cases having a response within the heart, whereas in China, the response seemed to be more so within the lung tissue. And again, there is also the adage of smoking as a risk factor, and the Chinese population has a high prevalence of active smokers compared to what we have in Europe.
Okay, so that's really interesting and helps my understanding of this. So we see higher amounts of cardiovascular disease in the Western world, and then viral load on top of that might mean a cardiac event happening, where smoking and lung disease being more common in, say, China and some parts of Asia, meaning we're seeing lung involvements as the disease gets more severe. That's really interesting insight there.
Yeah, and one of the other things that I think is also interesting, which again, it's difficult to get a grasp and a handle on the data at the moment, but we are reporting people as being COVID positive or negative. We're not actually reporting an amount of viral load. Mm-hmm. So we don't know, are these patients having a severe exposure and therefore having poorer outcomes because they're having more cardiac involvement or lung involvement than, say, someone that's had a very mild form of the disease that doesn't need hospitalization and ventilation. So it may be the fact that the amount of virus that you're being exposed to also has an effect on how severe the damage is to both the lungs and the heart. So
the life sciences, they're not easy sometimes, are they?
Well,
to make light of a serious topic, I don't mean to. Sorry.
Absolutely, it's not going to be a one case fits all for everybody with COVID-19. I'm afraid.
Fair enough.
But I think the good thing is that the vast majority of people that do have the illness actually respond very well and do recover. So we have to put that into perspective. Even though the numbers are grim and the data from around the world is grim, the numbers actually show that sort of upwards of certainly 80%, if not in the 90s, 90% of people recover after having COVID-19.
We talked a lot with our guest last week, Professor Damien Ridge, in terms of psychology and optimism and pessimism. His phrase was realistic optimism, I think it was, which is, you know what, it might be quite bad right now, but it will probably get better. And if I do get ill, I will probably be okay. I quite like that phrase, and I think you've come back to it there almost inadvertently. Yeah,
absolutely. And we have also worked with psychologists before, looking at patients with cardiovascular disease per se, and in particular those that have heart attacks. And we do know that patients that have a positive outlook seem to do better, and they have a lower incidence of reinfarction or further cardiovascular disease in 6 months, a year's time than those that have maybe a negative outlook. So it goes across the board, and I'm sure that COVID-19 patients would be exactly the same.
That's really interesting. And then as we talk about treatment in COVID-19 and surviving COVID-19, you wrote another article recently for public consumption about dexamethasone and how that works, because we've had a lot of buzz in the British media especially about dexamethasone being used to treat COVID-19. Now, dexamethasone is a steroid that we've had around, well, forever. So why do we think that's going to be effective in COVID cases?
So dexamethasone, as you rightly said, is a steroid. It's a derivative of cortisol. And it has a very potent response to the inflammatory system. So it can dampen down the excessive inflammation that we get in these patients with COVID-19. And we're talking about the severe ones again, okay? So that, we're not talking about patients that are in the community or in social care setting. We're talking about those that require oxygen therapy and mechanical ventilation. And what it does is it causes a global dampening of the immune system and reduction in the cytokine storm that we see, which is basically the process by which the body gets ravaged by the infection. And dexamethasone is very good at doing that. There are other drugs available. There's one in particular called remdesivir, which has a similar mode of action. The thing with dexamethasone is that, as you said, it's widely available. It's been around for a long time, since the very late 1950s. It's easy to manufacture. We have good global stocks, and also it's relatively cheap. And in particular, this has a major effect in patients that are in developing countries, because they can have access to a drug that will work, that is relatively cheap for their healthcare system. So if we take dexamethasone, a course of that treatment is for 5 to 7 days is roughly about £30–40. Whereas with remdesivir, you're looking at maybe a 5-fold, even 10-fold increase in that cost. And those countries probably wouldn't have access to those newer drugs. And also the US have actually just put in a large order for remdesivir, and actually have probably taken up most of the global supply of remdesivir at the moment. So dexamethasone is good, it's cheap, it works. We have the recovery trial data from Oxford that shows it's of benefit, and we can use it globally.
So there's two things to point out there, I think, that I want to pick up on. One, it's been around since the 50s, you say. I used it in my master's, and that wasn't that far after that.
You're not that old, Brad.
Well,
you're younger than I am.
I'm feeling older and older every day at the moment, honestly. As a researcher into human aging and an aging researcher, I'm seeing it happening in real time. It's not a very exciting show, but it is happening. And the other one was, and this might be confusing to people when they say, okay, so a viral infection is bad for me, so you're giving me an immune suppressing drug. Isn't that counterintuitive?
Well, you'd think it would be, because obviously then, the body could then be open to other infective agents as such. But we have to outweigh the pros and cons of using it. And the pros are that it has such a dramatic change in the cytokine storm that we see in these patients. So yes, there are side effects with the drug. We're using it in concentrations which are not that greatly toxic in the population. So we're not sort of dampening down or obliterating the immune system like we would in maybe, say, a leukemic patient, where we need to eradicate the cells. But what we're doing is modifying that cytokine burst that we see in the acute phase of the infection. So we're just making sure that we can dampen that down and therefore protect the tissues of vital organs such as the lung and the heart.
And therefore, I guess that makes sense in terms of why, as you mentioned already, but just to point out for clarity, that dexamethasone is recommended from the evidence we have for very severe patients, ventilated patients in a hospital. And the same Oxford data from my memory showed no effect at all in a general population or minor infections at all, correct?
Absolutely, yes. So people that have minor infections that don't require hospitalization will probably not benefit from taking dexamethasone. One of the other things as well is important is that people shouldn't rush out and try and buy dexamethasone or get dexamethasone online to use as a preventative, because that's another thing that's been advocated, whether or not it's a prevention of developing COVID. And this has also been occurring with other drugs, in particular hydroxychloroquine, the anti-malarial drug. And again, they don't offer protection from getting the virus, but they have benefit in patients that have severe forms of the virus.
Despite what certain world leaders might suggest?
Yes, absolutely.
All right.
Yeah.
A bit of a hard topic switch, because I wanted to ask you as well. You wrote another article that was slightly outside of your normal area of expertise, which is cardiac biomarkers. And you wrote about vitamin D and COVID-19. And this is an area where we both have work that overlaps. And there's a bit of controversy about whether or not vitamin D might be useful in terms of prevention of COVID-19 infection, or even minimization of infection severity once it occurs. So what's going on here?
Okay, so yes, you're quite right. This is quite a hot topic. It's a very polarized view at the moment. Data is suggesting that vitamin D may be involved somehow within the process of COVID-19 infections, but we don't really know the full mechanisms of how and why. There has been data to suggest that taking vitamin D may prevent severe forms of infection happening, but nothing has been absolutely proven with that particular theory. Vitamin D, as you know, and as most people probably do know, is either obtained through supplementation in a diet or by sunlight. And because the virus seemed to have taken hold within the winter months, and certainly in the Northern Hemisphere, the first 6 months of the year, we tend to find that vitamin D levels are very low in the population in general. And it may be the fact that those that took supplementation at that time may have had some form of benefit from not getting COVID-19, or maybe a less severe form of COVID-19. What we're not saying is that in the same way as dexamethasone, that vitamin D is useful as a therapeutic intervention in patients with COVID-19. So I think the data is quite, it's differential data from different populations. I think we have to put it into a bit more perspective. So we need to maybe look at sort of meta-analyses, large trials, and see whether or not cumulative data is of benefit or not. And again, we have the adage of the fact that we have a global population with this disease. So we have vitamin D concentrations in different areas of the world that are differing. So we could look at that in more detail. But I think, certainly for the UK, the recommendations from the National Institute of Clinical Health and Excellence suggest that taking vitamin D is of no benefit to preventing COVID-19 at this time. And the data that we have from the UK is suggestive of that at the moment.
Okay, so there's no great benefit at the moment that we have, according to the evidence. And to be clear, this is a relatively fluid situation and quite hard to measure, I'm sure, quite hard to test for. We can't just go giving people vitamin D, then sticking the virus in them and seeing if they get better or not. That's kind of frowned upon by our ethics committees.
Absolutely.
But at the moment, recommendations is there's probably no benefit. So presumably there's no harm from normal, and I'm going to underline the word normal there, doses of vitamin D in a population either.
Yes. So, I mean, there has been information in the national press suggesting these super doses of vitamin D, which can, in some cases, be actually toxic. So we're not advocating anything of that use at all. Vitamin D is useful for many physiological functions. So actually maintaining a good vitamin D concentration is good for everybody anyway, be it by the natural sunlight or by supplementation from the diet. So it's just, it adds to general health. But we also know that patients that have, say, the cardiovascular risk factors and the aging population, they tend to have lower vitamin D concentrations anyway. So it may be, it's a chicken and egg argument. Is it actually a risk factor, or is it something that's incidental in the population that gets COVID-19? And that's something that, further data is going to give us when we look in more detail.
Yeah, again, I think I mentioned it earlier, but I'll say it again. In this field, sometimes nuance is
Yeah,
necessary, and there's a very common misunderstanding, I think, of, well, some of this is good, so more is clearly better. Where
yeah,
normally, in
exactly.
terms of physiology, that's exactly the opposite to what homeostasis means, where you
Sure.
need an optimal
Right.
hormetic amount of a thing.
Yeah. Yeah.
Anyway, there's one other thing I really want to ask you about today, and it's completely left field to some of the serious conversations we've had so far. I read
Okay.
somewhere you once diagnosed a gorilla with heart disease. Is that true?
Yeah. Yeah. So this actually was a very tenuous way of getting into a new area of research. And we had a gorilla at a zoo in the UK that was being treated for heart failure. And we wanted to know whether or not that particular animal was responding to the treatment. So there is another blood test we can use, which is known as natriuretic peptide, which we use for heart failure, which is different to having a heart attack. And the natriuretic peptides are used in humans, and we use them routinely all across the world. So we measured this in a particular animal. But the problem is we don't have a reference interval. What's the normal for that particular animal? And then things started to progress, and we started to look in more detail. And we realized that actually there's a lack of concrete data giving reference intervals for great apes in our zoo collections. So this has led on to further work where we are working with a number of physiologists, cardiac physiologists and echocardiographers, and we are mapping and basically building a baseline both for individual animals but also for populations of what is normal cardiovascular parameters, if you like, from both physiological and biochemical in the zoo population. But what's quite interesting as well is that we now have access to some of the populations that are in captivity in sanctuaries. So they're not housed in great big metal cages in the centre of London. They're in their natural habitat, but are within a maintained environment. And we're seeing very different levels of prevalence of disease parameters and physiological parameters suggest that those in captivity are effectively like the human couch potato. They're getting diseases and cardiac profiles that are very similar to what we have in humans, whereas those that are in the sanctuaries tend to have much healthier cardiovascular profiles. But if they do die of a cardiac-related problem, it tends to be that it's either an animal virus or a bacterial infection, whereas the sort of heart disease type age-related diseases that we see in humans, we're seeing in the zoo population. So it's very interesting how it sort of just all of a sudden from one animal started into this. And we have data from captive apes across Europe. There is a similar great ape heart project in the US, and we have these particular apes from the Jane Goodall Institute in Congo.
That's awesome. But I think it's worth pointing out your problem with this was what are the reference ranges. My problem is gorillas weigh 600 pounds. I'm not sticking that thing with a needle, I don't care how well you consider it knocked out. They're a lot bigger than me. But what's the test?
You have to take things into consideration. So the animals that are in zoo collections are very well looked after, and they have a very dedicated medical team and husbandry team, and they are checked regularly. So they will be anaesthetized. They will have parameters measured. We take bloods at the same time, so they're done on roughly a sort of an annual basis.
Mm-hmm.
So it's a good way of building up a population and having baseline data for different species, but also for individual animals as well. So we can refer back to what's happened in the previous year, which is great because it's the term personalized medicine is affecting human populations, but we're now having personalized zoo medicine as well. It's great.
And I think that parallel as well between not wild, but sanctuary apes, and you making the reference to zoo apes, their inactive cousins being essentially us in terms of inactivity and chronic health disorders that we're seeing in human populations is really interesting. We've effectively imposed the human health condition on them, which is not a good thing.
Of course, that's right. Absolutely. And a lot of people advocate the fact that, zoos aren't the best way of maintaining our animal species. But at the same time, they are looked after very well. So, it's a double-edged sword. And, there's a lot of people out there that don't agree with the zoo collections, and maybe sort of more sanctuary type based natural environments for the animals is a better option. So, yeah, I think you're right. We have probably imposed that onto the animals at some point in the past.
Well, unfortunately, that's all we have time for this week. It only remains for me to say thank you, Dr. David Gaze, for joining us. If you've enjoyed this week's podcast, feel free to subscribe, whether you're watching the video version on YouTube or listening to the audio version on iTunes, Spotify, or whichever one of our audio channels you have. My name's Dr. Brad Elliott, and thank you for joining us for this week's Different Conversation.